Hi, everyone. Welcome. Grab a seat and get comfortable. You have just entered the Smartest Doctor in the Room podcast, where you can get the best information anytime, anywhere. I'm your host, Dr. Dean Mitchell. Today, I have back on a guest who is a pioneer, and I don't say that lightly, in the field of bioelectric medicine. You might be thinking, well, what is bioelectric medicine, and why should I care? Well, my guest today has proven that you can reverse certain autoimmune conditions with bioelectric stimulation. That's without medications. This is a very big deal. I want to take a moment to thank the sponsors that make this podcast possible. To all my listeners of this podcast, you probably know I have a lot of experience in diagnosing and treating mold-related illness. What you might not know is that not all mold testing laboratories are the same. In the past decade of diagnosing mold-related illness, I have used exclusively real-time labs urine mycotoxin testing. It's a spot urine sample that accurately confirms my patient's symptoms as they relate to the mold exposure in their home. Now, there are other labs that do urine mycotoxin testing, but I have found from my own experience that they are not as accurate and reliable as the real-time test. So, if you suspect you have a mold-related illness and go for testing with your doctor, ask them specifically that you want the real-time urine mycotoxin test. And you can say that you heard from Dr. Mitchell, it's the one that he trusts the most. In the first year of this podcast, I had recently read an article in Scientific American magazine, which had on the cover the bold title, Bioelectric Medicine, the New Frontier. I had no idea what that was, but as I read the article, I really became fascinated. The one key takeaway from the article was that the immune system and the nervous system were interrelated. This was not something that was accepted in the conventional medicine at the time. You know, I had always been interested also in mind-body medicine for quite a while. And actually, I remember watching the PBS series Healing the Mind with Bill Moyers, a great journalist who unfortunately passed away this past year. And with my immunology training and pursuit of doing functional medicine, I thought the article in Scientific American really validated this whole field of mind-body medicine, whereas previously it wasn't taken seriously. My return guest is Dr. Kevin Tracey. Dr. Tracey is a neurosurgeon by training, a world-class researcher, scientist, and a leader in the field of vagus nerve stimulation in connection to inflammation. He is the president and CEO at the Feinstein Institute at Northwell Hospital Systems here in my backyard in Manhasset. He is also an inventor of over 100 U.S. patents. Dr. Tracey is the author of the new book, The Great Nerve, which is a great read, by the way. And the subtitle is The Vagus Nerve and How It Harnesses Its Healing Reflexes. The book not only gets into the understanding of how the vagus nerve is critical in so many ways to our immune system, but I believe the book also boldly explores and clarifies certain non-invasive holistic techniques that could be beneficial to everyone. And finally, I know recently, I think Benjamin Netanyahu, the Israeli prime minister, was nominating Donald Trump for the Nobel Prize, which, okay, he's allowed to do whatever he wants. But if I was given an option of nominating a scientist for the Nobel Prize, Dr. Tracey would be my choice. He's done amazing work throughout his career. So I am super honored to have Dr. Kevin Tracey back on the podcast.
Thank you, Dr. Mitchell. It's so great to be here. I appreciate your kind words, and I look forward to our conversation about the great nerve.
Yes, it's going to be great overall. Just a quick note for our listeners. The first part of this podcast will be a bit technical, but we will try to translate. And it's so worth it if you stick around for the second half, because we're going to be talking about the practical applications Dr. Tracey talks about in the book, which anybody may be able to do at home. Okay, Dr. Tracey, let's get into the book and your fascination with the vagus nerve. Now, it's funny, I didn't know reading the book that the vagus nerve had a prior name, the great nerve.
and I think another name before that. So I'm going to ask you a little bit of a philosophical question here. You know, in medicine, as in mountain climbing, it's not typical. Like normally the first person to get there gets the name, right? I mean, we know, from being in your surgical days, anatomy, all these areas that were, discovered and named by the original guy, that doesn't usually change. Why do you think the name for the vagus nerve changed and was allowed?
Partly because Galen's name, the great nerve, perhaps wasn't specific enough, and partly because when Galen was doing his dissections, he was probably naming the vagus nerve and or one or two other cranial. He probably didn't get it completely right.
Okay.
So the anatomists centuries later, 15 centuries later, who named it the vagus nerve, they did exhaustive and exquisite dissections and traced it with much more clarity. Galen was fascinated by a nerve in the neck that he realized when cut would silence a squealing pig. So, of course, we have to recall Galen was the first physician scientist.
Right.
We're looking at a time centuries before anesthesia. And so a time when the dissection of human cadavers was prohibited. So he would do public demonstrations of surgery on animals, on sheep or baboons that were tied down and were still awake. And he demonstrated that when he cut a branch of the nerve in the neck, a little nerve branching off of the vagus nerve that he called the great nerve, that the pig became silent. And so he had demonstrated with one flick of his knife the fact that, first of all, the larynx, the voice box, your Adam's apple, is the source of vocalization. And second, he offered this as proof that the brain was sending signals through the nerve to control behavior in the body. So that was a second new idea. Yeah. And then in the ensuing years, he continued to work on the vagus nerve, and he and investigators after him realized if you cut the vagus nerve on both sides of the neck, that was fatal. And in writing the book and writing The Great Nerve, I realized that's the only nerve in the body that if you cut it on both sides, you die. It's the only one. And wow. So to me, that does make it great.
Yeah. Let's call it vital, the vital nerve.
So I put The Great Nerve as the title of the book, primarily to root some attention on the fact that here it's 2,000 years later, 2,000 years later, we still are figuring out for the first time the anatomy of the human vagus nerve. My colleague at the Feinstein Institute, Stavros Zanos, he runs a very large program. It's part of a NIH consortium project over several universities, and they are providing the first ever detailed map of all 200,000 fibers of the human vagus nerve, 100,000.
Oh, wow. Wow.
Well, think about that. It's 2,000 years. So I said that the anatomists who named it the vagus nerve or the wandering nerve, they had exposed it anatomically in some detail, but that was centuries ago.
Right.
So here, hundreds of years after it was first identified as the vagus nerve, we still don't have a precise fiber by fiber map of all 200,000 fibers. And now my colleagues are doing that. So it's a great nerve.
It's interesting too, because I remember I'm sure when you took anatomy in medical school, and I did also, you got the sense that like everything that could be discovered had been discovered. And really what you're saying too is when you think about the fibers within a nerve and what they do, it's almost like everybody with getting their cable TV and everything with all these hundreds or thousands of wires going all over the place. What do they really do? And we'll get into this in the book. You detail it's not, we just think of a nerve doing one or two specific things, but maybe within a fiber, it can do a lot of different things. I want to ask you, you mentioned, it's obviously you're a neurosurgeon by training, and just for our listeners, neurosurgery, and I've had a couple of the neurosurgeons on the podcast, it's very long, intensive training. Actually, I had Theodore Schwartz from Cornell on. He had written a book called Gray Matters, and he talked about, his work dealing with brain bleeds and removing tumors. Incredible guy. And the kind of work that neurosurgeons have to do is obviously potentially life-threatening every time they go to the OR. But you ended up going a little bit of a different direction after, I think you mentioned about 15 years of neurosurgery. And you mentioned, it seemed like you kept on coming back to that case of Janice, the little baby that had the burn unit, I think when you were a resident. Can you maybe summarize a little bit for the listeners how that case affected you and what happened?
When I was training to be a neurosurgeon at the New York Hospital, then Cornell Medical Center, now Weill Cornell, in the 1980s, I took care of a patient named Janice. That's not her real name. That's what I named her in the book to conceal her identity. But she had been scalded in a household accident, and she died in my arms. And at the point that she died of septic shock, we didn't know about the cause of it. We didn't know about cytokines. We didn't know about TNF. We didn't know that toxins could be made not only by bacteria, which we did know, but toxins could also be made by your own white blood cells. And those toxins could actually become the source of the problem. You and I were taught in medical school that everything the immune system did was good for you. Everything white blood cells did was good. And what my colleagues and I discovered because of this mysterious case of Janice was we discovered that molecules made by white blood cells, cytokines, are actually capable of causing lethal shock and capable of causing severe inflammatory damage. So it wasn't that I left neurosurgery to pursue research. I actually had been on a path of research all my life and pursued neurosurgery as part of my research path. The reason I am a neurosurgeon by training and a scientist fascinated by inflammation by career is because they began to converge. First with the case of Janice dying of overwhelming inflammation, then in an unexplained way, now we know because it was cytokines, and later discovering that signals in the brain traveling down the vagus nerves can stop inflammation. And so the two careers converged, whether that was by accident, by design, by intention, by the subconscious, who knows? But that's what happened.
Yeah. No, it was really fascinating how it's led you down this path. All right. I want to just set the stage for the listeners because I told them the first part was going to be a little bit technical. Again, and we learn in medical school, there are 12 cranial nerves that affect our sensory and motor systems. Just for example, for the listener, something called cranial nerve 3 allows us to open our eyelids and constrict our pupils. Cranial nerve 7, for example, is called the facial nerve, actually allows us to close our eyelids. It's what's injured when you get Bell's palsy. It also allows you to contract your facial muscles to smile and show your teeth. So just to get an idea of that. So my question to you, Dr. Tracey, again, and I know you started to explain a little bit too, what in your view makes the vagus nerve so special compared to all these other cranial nerves?
A few things. So first, yes, it is a cranial nerve 10. And second, we call it the vagus nerve, but you have two, like two thumbs and two kidneys, one on each side. And we call it the vagus nerve, but within each of these two vagus nerves, you have 100,000 fibers. So it's really not incorrect to say everybody has 200,000 vagus nerves. Now, what the signals that travel in the vagus nerve, most of them travel from the body to the brain. So the vagus nerve originates in the base of the brain, about the level of your ears. It travels down your neck on both sides, down across your chest, past your lungs and heart, down into your abdomen. And along the way, the branches, the fibers coming off the vagus nerve touch all the organs that you don't think about all day long. And those organs are functioning under reflexive signals, reflexively controlled signals that are traveling up and down in the vagus nerve. So when your kidney makes urine, there's a signal that goes up into your brain through your vagus nerve. And then there's a signal that comes back down your vagus nerve and other nerves to your kidneys to reflexively respond to that event. When your pancreas makes insulin, when your liver makes bile, all of these things are happening without you consciously thinking about it or controlling it. But it's all under the influence of reflex signals that function very simplistically like the knee-jerk reflex when the doctor taps your patellar tendon and your leg pops up and you said, "Who did that? I didn't do that."
Well, my patients still love that. They're so amused when I do that in the office. They go, "People still do that?" I go, "Just got to make sure it's working."
It's important, and it is the same basic principle that controls your heartbeat and your breathing and your blood pressure and your glucose levels in your blood. All of the deviations around a set point are sent up as neurological or neural information. Much of that input from the body to the brain travels up the vagus nerve. So that makes it's very special. The second thing that makes it very special is that the vagus nerve is one of the two branches of the autonomic or involuntary nervous system. So the voluntary nervous system is what you use when you sign your name or kick a soccer ball or take a walk. You decide what action you want to undertake, and then signals from your brain travel down your spinal cord to your muscles, and the event occurs. The involuntary nervous system, called autonomic, as in government autonomy, the involuntary nervous system has two parts, the sympathetic and the parasympathetic. The sympathetic is the fight or flight system, which is the encounter with a barking dog, or the jumping into freezing cold water, the pain and shock that comes with that fight or flight. The other half of the autonomic nervous system is called parasympathetic, and that is primarily the vagus nerve. The majority of the parasympathetic or rest and digest system is the vagus nerve. So the vagus nerve occupies a crucial role in keeping your organs functioning in a balanced, harmonious way that we call homeostasis or health.
Yeah. Basically, I'm so glad you were able to do that, because that was my question. I was going to have to describe it a little bit for the listeners, but you did it beautifully. And when I sometimes think about it, just for our holistic people listening, it really kind of is like the yin yang thing. If you want to get very superficial, it's that the parasympathetic system, as you mentioned, is like the calming system in our body, whereas the sympathetic system is our, hey, we got to fight or flight. There's the lion coming, got to run. Or your boss is coming down the hallway and he looks very angry. These are all the things that are just sort of part of our, the core of our system to function and remain. And the key is obviously really is balance, which we're going to get into. Now, you discovered something over 20 years ago, which was really revolutionary. That was not only at a basic science level special, but also actually what led to something extremely practical, in that a whole class of drugs were used and are used now to treat autoimmune disease based on what you discovered. So that was like my first nomination of your Nobel Prize. But can you explain for the listeners, like, this whole idea as simply as you can? I've had to go over it a couple of times myself, because it just sometimes gets so confusing, all the double negatives, about this inflammatory reflex, which you put on the book is a healing reflex. So could you try to explain that to the listeners? Because this is going to set the stage for the listeners about later on when we talk about bioelectric medicine.
Right. So the key to understanding the inflammatory reflex really begins with understanding inflammation. So inflammation is the heat, the pain, the swelling, and the redness that you see occur when you sprain your ankle or sprain your wrist, or when you get an infected mosquito bite on the back of your hand. Everyone has seen and experienced inflammation. It's a normal part of life. And so why is it normal? Well, because it is the process in which white blood cells come into an infection or an injury and accelerate the healing of the injury and accelerate the fighting off of the infection. So those are obviously good things, healing and host defense. So then why is inflammation, why is it bad? Well, it's bad if in cases like I experienced with Janice, the little girl who died from too much inflammation. It's bad if it's not controlled. So when inflammation doesn't resolve in a timely way, and when inflammation persists and expands rather than resolves, you end up with damage rather than repair. And so this fundamental idea of inflammation being the problem underlies conditions like rheumatoid arthritis and inflammatory bowel disease, multiple sclerosis. Many conditions are characterized by excessive inflammation. Now, most of us that walk around and we don't have too much inflammation. So why is that? Well, it turns out that in evolutionary time frames, if you look back over hundreds of millions of years of evolution, there's evidence for inflammation dating as far back as there's evidence of life. So inflammation evolved in the early stages of life. That means that evolutionary pressure also evolved mechanisms to control inflammation, so there wouldn't be too much. So the simple answer is that the inflammatory reflex is signals that travel up and down in the vagus nerve. When inflammation occurs, these signals travel up into the brain, telling the brain there's inflammation in the body. And the brain responds by sending signals back down the vagus nerve to stop or resolve the inflammation. And that up and down signal, inflammation present, inflammation off, is the inflammatory reflex. And understanding that provides a model to dissect out very exquisite and specific molecular and neurophysiological mechanisms. And we've actually now, after 20, 25 years of working on this problem, we've actually been able to isolate individual nerve fibers that secrete a neurotransmitter called acetylcholine that travel from the brainstem down into the area outside of the spleen. And these signals are electrical signals, which are converted to chemical signals, acetylcholine. And these are the signals that switch off the white blood cells and stop inflammation. So the inflammatory reflex is like the brakes on your car. It's the brakes on the immune system that slows down inflammation. And the vagus nerve is the conduit, the cable that carries those signals to turn off the inflammation.
All right, that was a great explanation. I know you may already know from listening to my podcast that I specialize in treating patients with toxic mold exposure. It's become a serious problem for many years as we deal with the hurricanes and floods throughout the country. You know, even simple bathroom water leaks from a toilet in your home over time can contribute to mold buildup. I can help patients that suffer from the symptoms of toxic mold, but I also rely on the patients getting their current residence inspected so they are not continually being exposed. My go-to person for mold exposure is Joe Reese. Joe is a certified mold inspector with decades of experience. He is super thorough and gives you a straightforward assessment and tells you whether it's safe to live in your home or if there is mold. I should know. I used Joe when I moved to my new home 4 years ago. Fortunately, when I moved in, I smelled an unusual odor in my basement, and I immediately called Joe. He came over with his instruments, and he found the problem. Afterwards, I had remediation, and the problem was solved. Joe does inspections all throughout the country. He welcomes calls to his cell phone at 908-451-4592. You can also reach him by email at jprconsultants7929@gmail.com. Remember, mold in your home is not a good thing, but thankfully it's a problem that can be fixed. And one of the things you don't really discuss in the book, I know maybe your center is researching, it's maybe not your specific research, that we do know in autoimmune diseases, and unfortunately they are so prevalent today. I mean, all you have to do is turn on your TV and every other commercial is for a drug for autoimmune disease. And clearly this vagus nerve effect, on the spleen and releasing of tumor necrosis factor plays a huge role. But are we any closer to understanding because I've had people on the podcast too, we talk about the microbiome. As far as we know, that people with rheumatoid arthritis and Sjogren's disease and a lot of these ulcerative colitis don't seem to have a clear-cut chronic infection. And like what you're saying too, it's inflammation. So do you think at the core, it's a neuroimmune problem that this is like the vagus nerve is out of whack? Or do you think possibly that there's this might be just obviously speculative in your opinion, but that it's a microbiome problem that's sending a signal to the vagus nerve, which you mentioned in your book is 80% sensory nerves, picking up what's going on in the body. They're like the antennas throughout the body that's then saying, we're not in homeostasis, rev up the system. And that's why they're getting this inflammation. Just your thoughts on this.
Well, the scientific answer is no one knows the answer to your question. There is a great deal of debate on the underlying causes and drivers of autoimmune conditions, the ones you named and others. There is some evidence that an underlying infectious agent might trigger autoimmune disease in some patients, whether it's a persisting infection or just a trigger of a then resolved infection. That's not known. We and many other labs of my colleagues have looked at the function of the vagus nerve in patients with various autoimmune conditions. Now, you have to be really careful with these kinds of studies because we don't have great ways of measuring the activity of the human vagus nerve. We can do it very well in the lab in mice, but it's very difficult. We don't have great tools for doing that in humans. So that with that as a caveat, you can look at secondary markers of the vagus nerve. And one of them would be something like heart rate variability. Now, if you look at heart rate variability, there are ways of measuring it by looking at the individual time between individual heartbeats. And the more variable that is, and the slower the heart rate is, those are indicators that the amount of activity in the vagus nerve is in the healthy range, or that's called having a good vagal tone. In patients with autoimmune conditions, there is abundant evidence, many studies showing that there is a relationship between decreased vagal tone and the presence of autoimmune disease. But as you know, having a correlation does not prove a causation, number one. And number two, the fact that the vagus nerve fibers that control heart rate variability are not functioning well or are impaired doesn't mean that it's the same fibers that go to the immune system. We can all walk and chew gum at the same time because individual nerves have individual functions. And I recoil at many postings and social media and on the internet in general that oversimplify this and say, well, if your heart rate variability is poor, that means your vagus nerve is impaired or dysfunctional. That means you're going to have all these other things. Well, not necessarily. You can have isolated damage to a nerve, and you can have isolated parts of the nerve that are healthy and parts that are not healthy. So it's a really important question. A lot of people are working on it and trying to figure it out. The reason it comes back to the microbiome in many studies is because there's very clear evidence that products of the microbiome, whether they're metabolites or even toxins, can travel up the vagus nerve and access the brain. This is a story that's being aggressively pursued in possible causal mechanisms in early Alzheimer's and even
especially I'm sorry to interrupt you, at Parkinson's. I've had some really top researchers on about that, and I think they said 50% of the cases when they've done the deep research they think is related to the gut, and obviously the highway from the gut to the brain is the vagus nerve. So they're and they're looking at different chemicals. I think it was called squalene or something that can affect all of these things. And this is like huge, obviously, in so many areas.
Yeah, there's even evidence that toxins created in the gut or originating in the gut can travel up the vagus nerve, and that initiates the damage that then occurs in the brain.
Dr. Tracey, how would that happen, actually, by the way, just so I can understand? Because when I think of a nerve, I think of like an electrical circuit, so it's so obviously there's it's physics. These chemicals, like you mentioned, acetylcholine or whatever, too, are released at sites of the nerve endings. But essentially, it's the electrical charge that's going down the nerve. How would an infectious organism travel? It's almost like saying, like, along a wire, you could send a bacteria or something. Is that?
Yeah, it's not the wire analogy is used by most, and it's not a good analogy. A much better analogy is a cell or a straw. Each individual fiber is a living cell.
That's a good point. Yeah.
And in order for the cell to be healthy, which most of us have healthy neurons most of the time, there is a constant flow of cytoplasm and of metabolites and proteins up and down around the whole cell, so that if something gets in one end of the cell, it can be propagated all the way back up to the other end. And that
makes sense. That's actually a really key point. Yeah.
Well, I mean, we've known this even dating back centuries to early studies of the rabies virus, where the rabies virus gets in through a bite, and it travels back up through individual nerve fibers to end up in the brain, where it becomes, or in the central nervous system, spinal cord, where it becomes fatal. So if you think about the nerves as copper wires, you're kind of missing out. And the other problem is, and I don't mean you, I mean, because that's what a lot of people do. The other problem with the nerve analogy as a copper wire is copper wires transmit electric current at about the speed of light, give or take. And there's actually controversy about that too. But putting that aside for a minute, let's just say the dogma is it's about the speed of light. The speed of transmission of electrical information from one end of the nerve to another is a fraction of that. It's much, much slower. It's fast in biological terms, but it's nothing like the speed of light.
Yeah, the funny thing, I guess the reason I, didn't think of it that way too is, like, again, when we used to do histology and all that stuff too, like, you always thought of a nerve cell is so different than another cell. I mean, like, I think, just for our listeners, nerve cells, if you ever see pictures in, magazines, it's like what they call dendritic. It looks like star shaped with things, where other cells you sort of picture as round or whatever. So I guess, I don't know, I just thought of it totally different things. But what I want to go back to, because I think the listeners are going to get very excited about this, and you're the guy that I really want to clarify this. Today there are so many devices, whether it's on their Apple Watch or your Garmin, or I don't know, what's it called? The Oura thing. I don't know. There's so many of these things now that claim to track, besides your calorie intake and your sleep and your steps, about your heart rate variability. Can you just also explain to me a little bit too about, again, because also when I was thinking about heart rate variability, I think about an EKG. And obviously in a good EKG, your rate of your heartbeat is regular unless you have an arrhythmia. But this is more subtle, right? So could you maybe explain, and are these devices, because I think a lot of people, like even my son came to me once, he goes, "Oh, Dad, my heart rate really looked really good." I go, "What does that even mean?" And are there, by the way, any numbers that you can kind of give us an idea, versus good or bad?
So basic principles again. So the reason your heart rate is regular is because you're looking at it at 60 seconds at a time. If you look at your heart rate from beat to beat, your beat to beat heart rate, and you're healthy, it's actually quite variable. And the reason for that is your heart is getting constant input from the sympathetic nerves, which tend to accelerate your heartbeat, make it go faster, which short on the other hand, the vagus nerve, the parasympathetic input to the heart, is prolonging the time between individual heartbeats. So every time the vagus nerve fires, it delays the onset of the next heartbeat. And so when you have lots of vagus nerve activity, a high vagal tone, you have more variability between the individual times of the individual heartbeats. So how does this really work in practice?
How do you assess that? So, like, let's say if I had a monitor device on when I was playing tennis, like earlier today, or if I was sitting and meditating, which I don't do that much anymore, but I mean, you're saying that there would be a significant change in my heart rate variability, and how would you assess that?
The easiest way to assess it is you can do it right now. You can feel your pulse, and you can take a big breath in on the count of three, a big inhalation, 1, 2, 3. And now slowly through pursed lips, you breathe out slowly on the count of 7. If you do that in several cycles, 2 or 3 times, you will notice that your heart rate during your exhalation is slower than during your inhalation.
I noticed that. That's right. Okay.
So that's heart rate variability. And the reason that you have it, we all have it, if we're healthy, is because it is inherent to the synchronization of breathing in, expanding the lungs with oxygen, and breathing out, exhaling the carbon dioxide. So you correlate, or you synchronize best the amount of blood that gets oxygenated when your heart rate accelerates a little bit during inhalation and slows a little bit during exhalation. It has to do with changes in pressure inside the chest. When you inhale, what happens is your diaphragm goes down and your chest cavity enlarges, which means that the pressure inside the chest drops. That changes the shape of the heart a little bit. And when you exhale, the diaphragm rises back up again. It compresses the chest. The volume gets smaller, so the pressure in your chest goes up, and that changes. Those changes affect your heart as well. All of those pressure changes and blood flow changes, at the end of the day, are controlled by signals in the vagus nerve and in the sympathetic nerves, and the coordination of those signals produces heart rate variability.
So are any of the devices good, though, to measure it? And can we put, like, I think I have seen it in some articles, can we put a number on, like, what's a good resting, baseline heart rate variability? Like, let's say if you were checking yourself and say, geez, Dr. Tracey's been doing really good lately. He's very calm, very focused.
I think, if you Google this, you can download tables of heart rate variability versus age and sex.
Okay.
And there's abundant data on this. Where it gets hard to give a simple answer to your question is that these devices are not sharing their algorithms, and the algorithms behind how they're specifically calculating heart rate variability based on the EKG changes, based on the millisecond alterations in the individual distance between individual heart rates, that there's not a lot of general sharing of all those algorithms. And so it becomes very difficult for a scientist to come in and say, this one's better than that one, or this one, this, you should interpret this one this way and that one that way. And that's, again, back to the sort of overwhelming billions of web impressions about the vagus nerve, all saying, do this, that, or the other thing, and do this, that, or the other thing for your heart rate variability. You have to really be careful about knowing the credibility, the validity of some of these claims, because there's so much variability in how the data is being collected and analyzed.
Okay. Before we get into, for the listeners who have hung around for this long time, I'm impressed. We're going to get into some very practical applications of this. But again, one of your groundbreaking work was doing vagal nerve stimulation through surgery to help reverse autoimmune disease. I mean, one of your most well-known cases was that gentleman in, I believe, Serbia, who had severe rheumatoid arthritis, had failed all medications, and was essentially, homebound. And by having one of your implantable vagal nerve stimulators through surgery, it was an amazing reversal of his condition, where he was out and about and back working, it's an incredible story for anybody listening to this, and really sets the stage for what I want to talk about in a few minutes. But just one last thing on this vagal, on the heart rate variability. I'm just out of curiosity, because I know you've looked at a lot of studies and done the work yourself. Do you see pretty significant changes in their vagal tone after these kind of patients have been treated with vagal nerve stimulation? like before their heart rate variability was minimal and maybe now it's a lot more variable?
It really depends on the device.
Well, how
So
did you guys measure it?
as of today, so we measured, my colleague Sangeeta Shivan and I at the Feinstein Institute at Northwell Health, we studied patients, healthy volunteers with no known autoimmune conditions, and we studied patients with rheumatoid arthritis at various stages. And in general, we asked patients to come into a study room and have essentially a 1 hour EKG and
A 1 hour
lying
EKG.
still.
Okay.
1 hour EKG lying still. And we did this many years ago, and we published it some time ago in peer-reviewed journals. And what we found was, in general, patients with rheumatoid arthritis, and there have been many studies, dozens of studies now done by groups all around the world, and the findings are highly consistent. Patients with autoimmune conditions, sepsis, serious inflammation from a whole range of underlying causes, they pretty much all have highly decreased heart rate variability, very low levels of heart rate variability. And this is consistent with the idea, the hypothesis, that impaired vagus nerve function is associated with increased inflammation, but it does not prove cause and effect. It's possible that the inflammation caused the vagus nerve dysfunction, which manifests as impaired or decreased heart rate variability. And it's possible that impaired vagus nerve function, which manifests as decreased heart rate variability, contributes or causes the underlying inflammation. But we haven't proved, no one's proved that in human studies yet, in clinical studies yet. But there have been some very suggestive results from clinical studies that showed family members of patients with autoimmune conditions. Now, family members are at risk of developing autoimmune conditions themselves in some cases. Many times, family members also had impaired heart rate variability, low heart rate variability, before they developed the onset of their autoimmune condition. So it's possible that the impaired vagus nerve function contributes to the onset of the disease, but nobody knows.
Let me ask you this too. It's interesting because I think it's been well known for a long time before this heart rate variability thing. Like people that were athletes, obviously long distance runners, probably most really, people that put a good amount of exercise in tend to have a lower resting heart rate, which again, I think, as you would say, probably reflects like a stronger parasympathetic vagal tone. So is that still considered like generally having, I mean, we don't want to have somebody who's got too low a heart rate, or what we call bradycardia. But if someone, let's say, if you were to take 100 individuals and, there was, let's say, 50 of them had heart rates like in the high 80s, 90s, and you had the other half that were in the 50s, 60s, would you generally feel that that's a person who's in better health? I mean, like, obviously removing other factors, they had an illness or something. Let's say if that other groups exercise pretty vigorously. Is that what's been seen and is really confirmed?
So it's been looked at in large population studies like the Framingham study, which was thousands of people over many decades, and even larger studies in France. And I cite all the references in the endnotes of the book, in my book. If you look at the Framingham Heart Study, the strongest predictor of lifespan, of longevity, was having, on a population basis, having a slower heart rate. So the population.
Wow, I didn't know that. Wow. Because they always talk about cholesterol and smoking, which I'm sure are all very important things, but so it's your resting heart rate. Wow.
Resting heart rate, a slower resting heart rate on a population basis was the best predictor of the longevity of the population from any other measure. Now, as you said, that doesn't mean if you've had a heart condition that slowed your heart rate, or some other illness that caused that. But in a healthy cohort, the lower the heart rate, the longer the longevity. And these findings were replicated in an enormous study in France. So what does that mean? well, we all learn in the first day of statistics, or if you go and buy a lottery ticket, that you can't apply population statistics to select an individual. And so if your listeners just felt their pulse and found that their heart rate is 92, it doesn't mean that they have a high risk of death. It doesn't work that way.
Right. No, it's over alarming. But the alarming thing to me is that I see a lot of young patients that are on stimulant medications for ADHD and other things, and their resting heart rate is usually like in the low 90s.
Right. But in the Framingham study, they probably didn't have that cohort.
No, I know. No, I'm sure not. But I don't think it's a great thing for them. But
I think the way to think about it, that's actually very simple and somewhat positive, is that if your doctor or your grandmother gives you basic health advice, it would be to exercise regularly, eat a balanced diet, get a good night's sleep, try to avoid too much stress and anxiety in your life, and have social connectivity and be integrated and active with your work life and your hobby life. And what do all of those things have in common? They're all associated with slowing your heart rate. So that's a good thing. And it doesn't mean it's one size fits all for everybody, but it does mean that an active vagus nerve is a sign, if not the cause, we don't know, it might be, but it's a sign of good homeostasis, of a good balanced functioning of your organ system.
Yeah, we're going to get into something a little bit deeper on that, but that's very interesting.
If you've been following the podcast, you may know I practice holistic functional medicine and immunology. In fact, at Mitchell Medical Group, we've been treating chronic fatigue patients for 3 decades. It's critical in this work to have a trusted pharmacy that can compound medications for our sensitive patients' needs. ITC Pharmacy has been our go-to pharmacy the entire time. They can make medications ranging from thyroid hormones to dye-free medications for all of our highly sensitive, even allergic patients. If you or your holistic doctor are looking for these very specific patient medications, you can contact ITC at 888-349-5453. They have licenses throughout the country and can have medications delivered right to your doorsteps. My patients have been so pleased with their service, and you will be too.
Okay, so I want for the listeners to some of the things that you mentioned in the book, which I thought were very practical. I just want to, again, lay the table on this. I mean, again, you are a neurosurgeon. A lot of your work has been on implanting doing surgery, neurosurgery, and implanting a vagal nerve stimulator, which you have without doubt proven can be effective in reversing autoimmune conditions. But you mentioned in the book, which I thought was very interesting, as you start to talk a little bit about here, breathing exercises, meditation, cold plunges, and even some other non-surgical devices. So that's what I wanted to ask you about. It's really funny. In our first interview, we were talking, and I'll never forget this because for years I thought about it since we got together again. You were mentioning, I think, to me, because I was talking about some of the non-surgical vagal nerve devices, and you were mentioning that even yourself, you were putting some type of stimulation into your ear to help with your vagus nerve. And it sounded something very similar to acupuncture. So anyway, can you tell us, you mentioned in the book about this, the TENS stimulation to the ear and how it's been used for Crohn's disease and opioid withdrawal and depression. So maybe mention a little bit about that for the listeners. I think they'll be very fascinated by this.
Let's find out one thing in response to what you said. I have not implanted vagus nerve stimulators for these clinical studies. I started a company called Set Point Medical in 2007. And the company sponsored the clinical trials, even for that first patient who was in Mostar, Bosnia, actually. I just want to be clear. I don't want.
That's correct. I'm sorry. You're right. That's right.
I did the research and then did the device. Yeah. It's kind of important and the second thing is that these TENS units, there's now dozens of them marketed for all different things. by many different companies. And you have to be really careful. We'll dive into it, but you have to be really careful because they're not vagus nerve stimulators. So there's two ways of stimulating the vagus nerve in humans. The first way would be to implant a chip in the neck, on the vagus nerve in the neck. And this is exactly what Set Point Medical did. And in fact, you said that we proved that it works. Last November at the American College of Rheumatology, the clinical trial results from 242 patients treated at 40 plus centers in the United States were released. And these were rheumatoid arthritis patients that had severe rheumatoid arthritis. In fact, they were having persisting symptoms despite attempting therapy with biologics like anti-TNFs and anti-IL-1s and even JAK inhibitors. So these patients had this computer chip implanted in their left neck, this vagus nerve stimulator, and many of them got better, significantly better. The study hit its primary endpoint. And even as we speak right now, we're waiting for the FDA to decide and announce their decision as to whether this idea that we've been talking about will be FDA approved in the coming weeks or months or days.
So it is not FDA approved as of now. I didn't know that. No, okay.
It's as of the time you and I are speaking, it's not. But by the time this podcast is produced and released, it may very well be FDA
wow.
approved.
Okay, that's fascinating. Okay.
So it's very current. The conversation is very current. So you can stimulate the vagus nerve in humans if you have a small surgery and implant a chip about the size of a multivitamin in the left neck. That's one way to do it. The other way to stimulate the vagus nerve medically in humans is with focused ultrasound. And my colleague Sangeeta and I have done that with our other colleague Stavros Zanos. Several other groups are experimenting with this. That therapy, that device is not generally available for clinical use. So those
I just want to clarify. Yeah, I want to clarify this because you mentioned this stuff in the book. Because I've actually, I'm going to jump around here a little bit because I've had two other people on the podcast. Because after I had my podcast with you, this idea stayed with me. And you probably are aware of too. There's something called the Vagal Nerve Society, where people are really trying to build this community because they have to figure out how do we clinically get this to patients? Who's going to be delivering and monitoring these patients? And I've had Peter Stotz on, who you may know of. I know he knows of you, who's done the Gamma Core device, and I recommend that for patients. That is FDA approved for migraine headaches. But we'll get into this because it seems like you're concerned about how these things work because that's again applied for my listeners to the neck. It looks like a little electric razor where you stimulate for 2 minutes on each side of the neck twice a day. I've also had on the podcast Dr. Dave Rabin, who I don't know if you know, he came up with the Apollo Neuro device, which is like a wristband you wear, or it could be in other areas. And, again, these are legitimate people. I mean, Dave had done many years of research at the Pittsburgh VA, working with vets that had really severe PTSD. And, again, his clinical studies showed that this device seemed to help, without pharmacology or less pharmacology to help these patients. So, and I know you mentioned in your book, which I had never heard before, of essentially applying an ultrasound to the liver area that helps. So can you go through a couple of these things? Because these are out there. People can buy some of them without a prescription. I mean, the Gamma Core you do need. The Apollo Neuro you don't, and do they work?
So there's a lot in there, and
I know, but I'm hoping you can kind of, give a little more in depth what you think. I mean,
Well, I think to begin with, I think we've got we're being limited by semantics right now.
Okay.
So vagus nerve stimulation in humans today can be done with two devices, two classes of device. One is you can put a stimulator directly on the vagus nerve, usually, as I said, in the neck, but possibly also somewhere else. Or you can use focused ultrasound, which delivers a very specific beam of ultrasound energy, and that can be targeted to hit the vagus nerve in the liver or potentially even in the neck. But the first device is FDA approved to treat epilepsy and depression, and there's been, I estimate, at least 250,000 patients, perhaps 1 million patients worldwide have been treated for that kind of surgery over the past 40 years. And so we know that it's safe. It can be done safely. We know the side effect profile. It does not have black box warnings. It does not cause immunosuppression. It does not cost $100,000 every year, like some of the drugs that are used to treat autoimmune disease. So vagus
And
nerve,
it's like a pacemaker, right, Dr. Tracey? I mean, it's the kind of thing like it's in your system, and can you adjust it, externally, I guess?
the devices that are broadly available now are usually adjusted once in a while. Usually they're
Like a pacemaker. Yeah.
like a cardiac pacemaker. The new devices that are going to be coming out from SetPoint will fire for 1 minute once a day, and they can be adjusted up and down by the doctor communicating with the device through a tablet. The older devices are usually set to fire on for 5 minutes, off for 5 minutes, 24 hours a day for life. So they're very different settings. The inflammation setting is a minimal amount of current for a 1 minute a day. Now, that's the implanted device, and the focus ultrasound is not broadly available. What about all of the devices that apply electricity to the skin, like the TENS unit, like the devices people put on their neck or their head or in their ear? All of those devices are delivering electric charge into the skin and the superficial tissues of the neck or ear or other parts of the body where they're applied. Do they stimulate the vagus nerve? Maybe. They're not stimulating the vagus nerve specifically. The harder question is, do they stimulate the vagus nerve? It's very, very hard to know that. We talked about it before. We just don't have very good, sensitive, and specific measures of vagus nerve activity for human clinical studies. Could they be stimulating the vagus nerve? Maybe. So then should people use them? Well, that depends on the amount of supporting clinical data. For some of these devices, and I won't name them by name, but for some of these devices, some FDA approved and some not, some of them have been subjected to very large, well-controlled clinical trials with appropriate statistical analysis. And when you look at the clinical effect of doing the intervention, putting a device on your neck or on your ear or on your head, and you have a good clinical trial data to support that, and it's cost effective, fine. And it's safe and it's not toxic or not dangerous, fine. But can we say that it's having its effect because it's stimulating the vagus nerve? No, the data are not there. And can we say that it will work for everybody? No. It's the clinical effects in most of these cases are nowhere near 100% of the treated population. And can we say it's cost effective? That depends. Is insurance going to help pay for it? What is the,
Well, I'm more interested in efficacy. I was like trying to picture, like you're saying, you're putting an ultrasound against the liver. Why wouldn't a device that goes right up against your neck where the vagus nerve is coming out?
No, the ultrasound penetrates. The ultrasound is not available. I
know, but I'm just saying in comparison, if you were doing your lab.
There's no comparison. The ultrasound travels deep into the tissues, and then at the depth, it actually sends the activating signal. Electricity hits the skin and starts spreading immediately.
Okay, that's a good point. But how does, like, with the liver? I mean, how could, the ultrasound, it can get so specific to touch the fibers in the liver that have the vagus nerve?
Well, there's a trunk of the vagus nerve in the liver in the porta hepatis. So you have a discrete anatomic location where there's a large bundle of vagus nerve fibers. And it so happens that those vagus nerve fibers in the porta hepatis are transmitting, they're called glucose sensitive fibers. So when your glucose level rises, those fibers are activated. So by targeting those fibers in the porta hepatis with a focused ultrasound, you trick the brain into thinking that glucose levels rise, even though they haven't. And that drives the release of insulin and suppresses the release of glucagon, so blood glucose drops.
Wow.
So see, to the point that you can explain in exquisite detail what I just said and apply that to the other locations, the arguments break down. Engineers have looked at the specificity and selectivity of, for example, putting an electrode in the ear. Is that a specific vagus nerve stimulator? Absolutely not. There's 5 other nerves in the ear. If you put electricity into the ear, you might target a branch of the vagus nerve called the auricular branch of the vagus nerve, but there's no excluding the possibility that you've also activated other nerves.
Well, you mentioned in the book, one of your colleagues, it stimulated his bladder. He had to run to the bathroom.
Yeah, we don't know how that happened, but it's a true story.
Yeah.
And when you look at applying electric current into the neck, first you have the skin, then you have the fascial layers under the skin, then you have, and the platysma muscle, then you have the sternocleidomastoid muscle, and then you have a sheath encasing the carotid artery and the jugular vein and the vagus nerve, and then you have the vagus nerve.
I get it now. No, I get it. I'm getting the clearer picture. So yeah, I mean, because it sounded great in theory, and it's exciting because obviously, I'm not saying, implanting a chip on your vagus nerve is not a bad idea if you're suffering terribly. But of course, in medicine, we strive to do things more non-invasively, if possible.
Well, I think there's a caveat there too. So I agree with you, of course, if possible, but you have to look at the whole picture. So now you have a condition like rheumatoid arthritis where patients, first of all, they're suffering, despite the fact they're taking invasive medications that are immunosuppressive, cost $100,000 a year, and work half the time and have a huge range of side effects. So it's not the risks of invasive versus non-invasive. It's the risk of treatment and benefit versus poor treatment and no benefit. It's a totally different calculus.
Yeah. Okay. Let me ask you this too, because you mentioned in the book, it's kind of interesting, and you mentioned you do in your own life. I've also done a lot of training with, fortunately, really good places. Like back in the day, actually, I went up to Harvard and did one of the workshops with Dr. Benson, who worked on something called the relaxation response. And he was very big on meditation or prayer. I prefer prayer. You talk about in the book about the cold plunges, and you did some work with Wim Hof, who's known as the Iceman. I've heard of him through Tim Ferriss. These are definitely not devices. They're, what we would consider the holistic, and some of the people call it the fuzzy wuzzy stuff. But you mentioned you do this in your own life, and that it seems to bring you feel better, a happier place. Can you expound on that a little bit about if you think the value of doing some of this if a person's so inclined?
I believe that, as we discussed a few minutes ago, there are some basic health principles that converge on slowing heart rate and lifestyle interventions that focus on reducing stress, anxiety, and quote unquote increasing relaxation, which also converges on slowing heart rate. And I believe that the evidence is that those interventions, those practices are associated with better health span, with better lifespan. However, before we get into the specifics of what I do, I think you would agree with me that one has to always be really careful on general recommendations when some patients, it may not apply. So for instance, after COVID, we saw clear evidence of patients who had suffered from severe COVID who had anatomic and at autopsy pathologic evidence of damage to their vagus nerve. Now, the virus appeared to have infected the nerve, and in some cases, the inflammation around the nerve appeared to have severely damaged the nerve. So if those patients did all the extra sit-ups and push-ups and did all the ice baths in the world and all the meditation in the world, but their vagus nerves were damaged, they weren't going to gain the benefit from it. So I think you have to be I try to be really careful in not putting any blame on patients, because sometimes if the vagus nerve is damaged, then all these interventions are not going to make a difference. And I think that's important too, because in those cases, it is possible that a device or a surgical intervention may actually be more effective than any.
Can you heal the nerves like in other things? So again, you're not understanding with, on the nerve cells. I mean, could we always get I remember always being taught like nerve cells don't really regenerate or whatever. I mean, can a damaged vagus nerve heal?
So I think we're learning about that now. Some nerves can definitely heal. Some nerves can undergo injury or damage and recover. If a nerve fiber dies, it cannot be brought back to life, of course. But the textbooks, as you correctly say, the textbooks all say that that nerves don't regenerate in adulthood, but some of that work is some new work now looking at regenerating nerve cells in the brain is beginning to overturn that thinking too. So it is possible to apply, healthy life strategies that culminate in slowing your heart rate that may in fact be increasing signals in your vagus nerve. But once again, the vagus nerve is the conduit. It's not the server, right? So the server has the server has the movie on it. And so if there's a movie out of server in New York and the server sends the movie through a transatlantic cable to Paris and the submarine's going by and wants to watch the movie, they can tap into the conduit, into the transatlantic cable and watch the movie in the submarine. But the movie's not in the cable. The signals are going back and forth. The movie's sitting on the servers. And that's really the vagus nerve story. So if you meditate, the server's the brain, and you change the setting there, which sends signals down your vagus nerve, and you might manifest them as better digestion or a relaxation feeling in your abdomen or a slower heart rate. If you induce a change in your breathing, that's going to be mental because you're thinking about it. So you've got to activate the brain server, but you're also forcing a different respiratory pattern in your body, which is also sending signals back up the vagus nerve into your brain. So now you have this dual effect on the two servers. It's not the vagus nerve. The vagus nerve is the transmitting cable.
Yeah. Just as like a slight tangent, because I want to get into the cold therapy too, which I like doing a little bit, probably not as adventurous as you are. But it's funny too, because I remember also there was a football player on the New York Jets. This was maybe a decade ago. He had like a cervical spine injury, those dangerous ones that, you get paralysis. And there's always that question, is it going to be permanent? Is it temporary? And I think if I'm not incorrect, it was like one of the therapies besides giving steroids to reduce inflammation, they would also use some type of cold therapy or keep the body temperature low. Does that make sense in some of these things, or are you seeing that being applied? And is that all related, you think, to the vagus nerve, or is that too big a stretch, what I'm bringing up?
No. As you know, I spent a lot of time on this in the book. As you know, there is a lot of information out there on the benefits of cold therapy. And there's a lot of information on the internet and in social media that cold therapy is good for you because it stimulates your vagus nerve. Well, sort of. The first thing that happens if you do a cold plunge, whether it's a jumping in an ice bath or jumping in the ocean, cold ocean.
I wanted to ask you about that too. Because I can remember when I was younger, we used to watch these movies in school, like never jump into a cold pool when you're old or something, get a heart attack.
So cold therapy is widely being touted and advertised all over the internet and social media as an anti-inflammatory mechanism everybody should do.
Yeah.
The issue comes is you really should never do that without checking with your doctor first. There are some risks to this, particularly in people with heart conditions or other conditions. But if your doctor says it's okay, what happens when you have a cold plunge or a sudden cold exposure is your initial response is a massive fight or flight response, which is sympathetic, not vagal. If you stay in the cold for a while, you will have a relaxation response and you will notice your heart rate slow. Now you're having a vagus nerve stimulation effect. What's interesting to me is that both of those are anti-inflammatory. So a massive fight or flight response, a robust adrenergic or a robust epinephrine, norepinephrine response is anti-inflammatory. It suppresses inflammation. And stimulation of the vagus nerve, as we've been talking about, is also anti-inflammatory. So I think there is pretty good evidence. You'd be surprised, though. I was very surprised when I was working on the book for the last couple of years. I was very surprised how little really good studies there are of this basic question. I found some good studies, in fact, and I cited them all in the book. So I'm pretty confident that what I'm saying holds up to pretty good, rigorous, well-controlled studies. But there's nowhere near as much clinical evidence done in a quality way as you would think based on the billions of web impressions you can find.
Yeah, I know. But and you mentioned in the book, I kind of like to do it a little bit too. Probably I don't do it cold enough because it's so awful. But I like to when I'm taking. I love hot showers, and after I play tennis or do exercise, that's like my reward. But that what I find, like what you mentioned in your book, that if I do like the last, it's probably 30 seconds of like the cold, like turn on the cold on that. At first, I'm like, what am I doing this for? But after like the 30 second, 40 second, I do feel a little bit like rejuvenated. I guess it's almost like, I guess the nicer one is like when you shave, for us men, you're doing the hot shave and everything, and all of a sudden you splash the cold water on your face. There's something about that, I guess, right?
It's fascinating to me. So I find that, first of all, some people say, "Oh, I get used to the cold." I'm not sure. I don't. I've been doing it now for several years, a couple times a week, 2-3 times a week. I do it, and I'm not convinced I'm getting used to it.
It never gets better.
No, I find it highly uncomfortable. But what's fascinating is after, say, a minute or two, I find that I'm aware of it, but I don't have the same emotional reaction.
You disassociated.
Yeah. And that's interesting to me. It's almost like I'm watching somebody else suffering in the cold. And I do. And that is when I notice that my heart rate will, if you check your pulse, that your heart rate will slow. And so that requires a couple of minutes. It doesn't require a tremendously long period of time, but it requires that you get through the fight or flight response and get into the vagus.
So you would say roughly like 30 seconds to a minute minimum, probably.
I would say probably more like 1 to 2 minutes minimum, and 3 minutes ideally.
Okay. I want to just do one other thing before I sort of rounding things up here, but I couldn't help but because it's come across in my in the podcast stuff or whatever too. There is a Dr. Stephen Porges, you may be familiar with, who's put it forth in 1994, what he calls his polyvagal theory. And he divided that. Now, he's not a neurosurgeon like you are. He's a psychologist, but he somehow came up with this theory that the autonomic nervous system is divided into basically 3 components. He discerned that there's a ventral branch of the vagus nerve, which he said reflected positive states of relaxation and social engagement. He said there was a second, the dorsal branch of the vagus nerve, which he says shuts down the body and sometimes is associated with depression. And then he mentioned there was the third, the spinal sympathetic chain, which, as we talked about, it is involved with flight or fight. I was just wondering, I mean, again, you've done some of the incredible, scientific work. Is there reasonable good evidence on his theory being correct? Are you aware of it? I wasn't sure. Are you familiar with his work?
So I'm not a psychologist.
Right.
I'm aware of his work, and it's widely cited by many psychologists. It's not cited so much by developmental biologists or neuroscientists. There's a lot of questions about the origin of the theory and how it relates to basic anatomy and basic neurophysiology. There have been some reviews that have called into question some of the basic premises of that theory, and those are published by others elsewhere who are expert in that. It's not what I have been working on.
Okay, I just wanted to check if it come across. I know it really isn't what you are. It's funny because he mentions even in one of his books too that they can tell whether a person's vagus nerve is dominant or which one based on a person's handshake. Which I don't know. I mean, some people have bone-crushing handshakes, other people not, and it sounded a little too simplistic to me, but...
I can't really comment on that.
That's okay.
To me, that doesn't sound like a psychological theory. I mean, the nervous system evolved over hundreds of millions of years with trillions of synapses and connections, all wired with specific functions to do specific things at specific times. And I don't really know how to integrate a psychological theory into a
no, it's all right. That's fine. Okay. The last part, what I wanted to ask you about, you discussed this in chapter 11, which I thought is a very relevant thing. You wrote the chapter 11 titles, How to Talk to Your Doctor. And I interpret as basically saying, what should you ask your doctor about? And, it's really amazing, Dr. Tracey, in today's world. Like I see this every week in my practice now. My listeners, I'm sure people, my listeners of the podcast and my patients, they're using ChatGPT to get so much information. But I like to say, I mean, I like the discussion I can have with my patients, because they're more informed, but nothing overrides experience, in my estimation. So how does a patient find the right person to do VNS, vagal nerve stimulation treatments? It's because, again, this is emerging field, and it can leave itself open to a lot of people. There could be chiropractors, acupuncturists, probably fewer MDs than it should be that are doing this work. If somebody called you up, whether out in the West Coast or in Europe or something, and they said, Dr. Tracey, we know you're the leader in this field. My family member is suffering terribly, with an autoimmune disease, rheumatoid arthritis or migraines or whatever, and we want to maybe look into this treatment. How do they go about finding the right avenue to get treatment?
Well, as I mentioned before, as you and I are speaking right now, we are waiting on the FDA to announce its decision on its approval or not. I hope the answer is a definite yes, to use vagus nerve stimulation to treat rheumatoid arthritis in patients in the United States who are out of other treatment options, meaning they've tried other things and it doesn't work. So that will be the first step for vagus nerve surgery implants beyond the historic use in epilepsy and depression. So you're talking now about probably 1.5 million eligible patients in the US who have rheumatoid arthritis and is not being treated well. So that's a large patient population. Currently, the company who will have the device, SetPoint Medical, the company that I co-founded in 2007, they will be launching a product and they will be distributing that product through specific medical centers. So the best resource for your listeners with rheumatoid arthritis would be to go to the SetPoint Medical website. Now,
okay.
At Northwell Health, we opened several months ago in preparation for this wave, as you mentioned, this coming wave of bioelectronic therapies, which I fully anticipate will evolve over the next several years. We opened a new clinical center for bioelectronic medicine where we're convening the neurosurgeons, the rheumatologists, the gastroenterologists, and the neurologists, bringing everyone together to begin building a network of colleagues to share best practices and to develop the field for the patients. This is going to transition from a research project that's now, for me, 25 years old, into a active clinical program. Now, you mentioned in chapter 11, it's the Q&A chapter. I didn't just write that for the patients. I wrote it for the doctors too, because as you said in the very beginning of the show, you and I learned a little bit about the vagus nerve in med school, but pretty much nothing since then. And as we've been talking about, there's a lot of new knowledge since then. And so in the book, in The Great Nerve, I tried to lay out a series of resources, not only for the patients, but also for the interested physicians. I think this is going to be a significant change in how healthcare approaches patients with inflammation and how patients with inflammation approach healthcare. Everybody's going to have to think differently, right? There's going to be different referral patterns, different payer patterns, different regulations, different ways of doing everything. And as you know, medicine resists change. It's not because doctors are stubborn. You don't want your doctor chasing every shiny new object. You want everybody to be careful and thoughtful. But this is going to be a big change, and I'm trying to help accelerate the progress, because in the hundreds of patients I've talked to, they're looking for something else, and this might be it.
Yeah, I think that's a great way of explaining it. I'm really excited to hear about that center. In fact, because since I'm in New York, Long Island, and New York City, I would love my patients to have access to that, or to work with doctors that are doing that kind of work. Dr. Tracey, I think even after our first podcast several years ago, when I explained to some of my patients about the work on vagal nerve stimulation, I try to explain to them, I said, what excites me the most is that, back in history, medicine went from, being an area of voodoo where people were afraid to go to a doctor, where anatomy translated into surgery to really elevate our profession. And then I say the next wave came really, I think, from chemistry, which led to a lot of, pharmaceutical drugs that helped improve people's lives. And I agree. I think the next wave is really physics, and it's this electric medicine, which could be an amazing game changer for the future of our patients. So there's not much else we can say. We talked for quite a while. I am so grateful to the work that you've done and what you've contributed, and I really don't minimize it. I mean, you are really a giant in the field. Is there anything else you'd like to add before we finish up?
No, I want to thank you for having me on and congratulate you on the progress in your podcast over all these years and for getting out so many interesting conversations. I appreciate being on very much.
Yeah, it's such an honor. Please, again, for our listeners, The Great Nerve. It is really a special read. For any of my colleagues, my physician friends, it's a must read. So anyway, thanks all of you for bearing with us and listening to this longer than usual podcast, but I think it was very special. Dr. Tracey, thank you so much.